Yeah, sure. Yeah, yeah.
Ali,
Yes. You get to start.
start. I introduce you. Good morning, ladies and gentlemen. We will begin to session cornea symposium 2. We can begin already by Professor Ali Zain, who will speak about rotational grafts.
Yeah, thank you, madam. Thank you for inviting me. Today we are going to discuss a topic regarding which is basically part of the keratoplasty. Instead of going for the whole full blown keratoplasty, we are using and utilizing the cornea leftover, which is okay. Slide, please. Start the slide. Okay. Basically, as you all guys know, that this is the most commonly performed procedure all over the world, and 360 rotational graft is a novel concept in which small part of the cornea is opaque and the rest of the part of the cornea is clear. So instead of going for the full-blown keratoplasties, we decided that we utilize the remaining part to clear the visual axis. In this way, we are not able to get the patient good vision, but also we are going to have the chances of graft rejection and all the other complications regarding the keratoplasty would be reduced. Suppose this is one of the just recently performed procedure. Look at the corneal vascularity. The pupil is dilated. The patient is able to see only when the pupil is dilated to some extent. The patient total vision was not more than counting finger in this particular case, and his center corneal opacity was there. So what we did was that we rotate this corneal opacity and made the visual axis clear. And in this way, not only the patient vision improved from counting finger go up to 624, and he was able to have a very clear. There's no graft rejection. There is no chances of no corneal new vascularization, and the patient overall performance was. When he was doing so good after that, I in my practice normally if I get such patients like, I mean, suppose this is the patient who healed corneal ulcer. In our setup, we get a lot of patients secondary to corneal ulcer. Once they get healed, the central opacity is there. They will not be able to do good with the vision. Maximum post healed vision is 660 or maximally by 636, not more than that. Even if we have a very good healed corneal ulcer. So what we did in these kind of patients, we utilize this peripheral part of the cornea, and we take this central opacity up and we keep once initially after the surgery the patient post-op vision slightly would be less, but afterwards the vision improves once we remove the sutures, and the patient is going to have an excellent vision, and he's far more comfortable afterwards versus, and same is the case with this, this patient. I'll just show you. This is the whole cornea is all if we go for the whole full thickness penetrating keratoplasty, the chances of graft rejection and all that and the visual prognosis takes at least a year for these people to get some good useful vision, and that useful vision with all good gadgets and all that would not be more than 636 and 660. And but with this rotational graft, the chances of graft rejection is almost nil, and the useful vision goes up to 612 618 post-operatively once we the everything, and when the healing. This is just try to show the novel concept. We are removing the this is an ongoing studies. Now we are still working on this. We are including the criteria. We have so far we have operated upon 22 patients, if I'm not wrong. Yes, yeah, we have so far we have 22 of these patients which have been operated. All those patients we have the central corneal opacities were included, and adherent leukomas and all that, they were included. Exclusion was those patients whose the part of the cornea was not available. We have to utilize in 360 rotational keratoplasty. We have to utilize only the good useful part of the cornea. If the useful part of the cornea is not available, and or endothelial or other dystrophies, or there is marked vascularization, then the chances of having the useful vision after the rotational keratoplasty would be less. Just show me one video. I just have to show you the last video, and then we are done with the talk. इसका दिखाना जरा वीडियो दिखाना. इसका fast forward कैसे करना? Okay, it's just, I mean, this is another case. किधर से? Fast forward. This is the case. The only thing why I included this case, because the most common thing which happens once you're trying to remove the once you're trying to remove is the high intraocular pressure. You know, the iris start to popping out. So that was the one maneuver which we normally do in such kind of procedures, because the graft size is less and the recipient, we normally do the vitreous tap, and we remove the vitreous from the posterior chamber. That induces the pressure, and the chances of expulsive hemorrhage is less post-operatively. So I mean, this is one. इसको दिखाइएगा जरा. And once we were able to fully basically, this is we are cutting the cornea, and afterwards we are going to rotate it on the same plane. And we are going to make the center part clear, and we're removing the opacity. This is something, I mean, it looks like this whole new cornea was implanted, but this was the same patient. Thank you very much. Any question? I hope, yeah, sure. Yeah. Yes. Rotate it, yeah. Visual access, this one thing, huh? It's agreed. That's what I'm saying, that 6 months, almost roughly 3.5, 6 months. Yeah, roughly a year time. This is one part. But suppose and the patient which has got the adherent glaucoma, total opaque, how much the vision patient is actually having at the very moment. He's got hand movement of PL vision. He cannot see anything at that very moment. Once we remove it and we rotate it, we are going to have at least 660, 636, at least, even with the high astigmatism. And we can correct the astigmatism with multiple ways, with toric IOL and all that, and LRIs. But the first thing was to give a tissue which is viable and which is workable. That was the basic, aim. The workable condition, the patient should not have a chance of any rejection. The patient should not have any chance of infection and corneal neovascularization and all. So after a year time, these patients, they were very happy. I mean, they were obviously right after the surgery, they say there's an improvement, but there's not a marked improvement. You know, this is what they are expecting. But once you the whole cornea is healed and remove the sutures, it's a practical vision. Yeah. No, I just right. So Mariam from Morocco, professor, and she's going to have a talk on biological stimulation, new therapeutic alternative in intraocular surface disease.
Thank you very much, and I am happy to share with you the first use of the biological autologous platelet gel in ocular surface diseases. So what is autologous platelet gel? It's a combination of a platelet-rich plasma, PRP, and autologous thrombin serum. So we perform the PRP by centrifugation of the blood, of autologous blood, and we add the autologous serum. The platelets will give a growth factor This growth factor will stimulate the stem cells to their migration, differentiation, and proliferation. And the thrombin serum will use to convert fibrinogen into fibrin monomers whose polymerization form the clot. This so we will have a 3D fibrin matrix in which platelet-rich in growth factors are interrupted. So what does the literature say about this? So PRP or papers published, PRP due to the concentration in growth factors would be effective when the ocular surface scarring throughout anti-inflammatory and neuronal regenerative effects. But this meta-analysis show that critical to assessing whether PRP is effective are the large number of variables in these studies, including the method of PRP preparation, which influence the composition of PRP, type of application, type of wounds, target tissue, and diverse animal model and clinical study. So we have, there are several types of PRP, and there are several preparation protocols. So we try to have what is the good quality for PRP to be efficiency and safety for the ocular surface. First, we have we must have a good composition to be PRP will be efficacious. So first, very low cell contamination. The second is to adapt platelet concentration. The concentration must be 1.5 to 3 times, not more. And we must have integrity and functionality of fresh platelets. These fresh platelets, not frozen and thawed, and therefore burst resin the growth factor in bulk, so allows the progression and orchestral release of the growth factor at the level of the administration on the seat. So we will have gradual release of growth factor by platelets. The quality is by the preparation to have the preparation must be non-operator dependent, and therefore standardized and reproducible preparation, constant quality. Also in a closed circuit, ensuring the safety and non-contamination in the PRP. This we have this quality of PRP by Region Kit Ophthalmology distributed by Region Lab. The preparation of autologous platelet gel, it's 10% of thrombin, autologous thrombin, and 90% of PRP. Though the first clinical case, it's a puke. So we have two peripheral ulcers in rheumatoid arthritis with lambate and scleritis and episcleritis. It was a refractive, it was no response to the treatment. So we prepare the platelet gel, and we do the surgery. It's what to, yes, to put the pieces of autologous gel on the ulcers. So the results was very nice, and we have cicatrization and disappear of the inflammation. The second patient is a perforated trophic ulcer post-cataract surgery in MGD. So we put a piece of fibrin gel seen in the perforation and overlay on the ocular surface. In this case, also the results, it was very nice, and we have the cicatrization, and the perforation is now disappeared. The third patient, it was a chronic herpetic neurotrophic ulcer with a huge neovascularization, and the results also, it's very good. And this in this patient, therefore, the platelet gel has a strong anti-inflammatory and neuronal regenerative potential. These are the first 10 cases we did with this surgery. The indication was donc four patients with perforated ulcer, 4 persons with neurotrophic ulcer, and 2 persons with severe dry syndrome. So we have until case good anatomical and functional results, ulcer healing in 10 cases, and 100% improvement in visual acuity, 1 case healing by 2 procedure. The visual acuity is very, very increased in all cases. And in conclusion, autologous platelet gel could replace amniotic membrane transplantation. This is the question. So we can say that the autologous gel is clothing and filling off loss of substance, support for matrix healing, remarkable anti-inflammatory effects, strong potential for regeneration of the corneal epithelium and the corneal nerve glogin. The biologic stimulation of damaged tissue consists in using the regenerative potential of the tissue through platelet growth factor release by recruiting local stem cells. Also, the indication with all regeneration of the ocular surface diseases. The first cases are in progress to be published, and I invite you to Casablanca for the 35 National Congress of Ophthalmology, which was by the 9th Congress of Ocular Surface and Contactology. Thank you for your attention.
Thank you very much. How you apply that platelet-rich, how you actually applied over the ulcer this platelet-rich content? How, I mean, the gel-like thing, how you apply?
Before the surgery, we get the autologous blood of the
No, how you actually placed it over the cornea?
over the cornea. I put the gel, and after I put 2 or 3 millimeter fibrin tissue
Soaked in.
called
Right.
glue.
Oh, yeah, that's
Glue,
okay.
but glue prepared by
Right,
the
right.
blood of the patient.
Right.
It's a biological autologous glue. And after a contact band, lenses,
Right.
bandage, it stays there. Because of the
Glue, because glue की वजह से it will remain stable.
When we increase the
Yes,
concentration
yes.
of autologous of thrombin, we have the glue, fibrin glue, natural fibrin of the patient,
Yes.
who fix the gel. It's the first that it's used in ophthalmology, because the gel, the autologous fibrin gel, it's used for burn, cutaneous burn, or when you have a mock of substance in aesthetic, but in ophthalmology for healing of the ocular surface is the first cases.
Yes, ma'am. Thank you.
Thank you. Yes, so the gel generally it's absorbed in 7 to 10 days. So the follow-up is the day after the surgery, and in 1 week. So in 1 week, generally we have the gel is absorbed and the healing is there. The mean of the cicatrization is between
Yes.
2 to 3 weeks.
Right.
Cicatrization of the ulcer and the regression of the inflammation.
Thank you very much, ma'am. Yes.
The cost of the kit it's like $150 the kit.
So we are running short of time. That was very nice talk actually to stimulate. So next speaker will be the contribution of anterior segment OCT in corneal graft. Oh, sorry.
Thank you. First, I would like to thank Professor Hossein for his kind invitation. I will talk about the contribution of ASOCT in penetrating keratoplasty and deep anterior lamellar keratoplasty, and I have no financial interest with this topic. So, as you know, the success of corneal transplantation mainly depends on the graft quality and surgical experience, but careful postoperative monitoring is also essential for the prevention of graft failure. Anterior segment OCT allows qualitative and quantitative analysis of the cornea and the iridocorneal angle. Before talking about the post-operative ASOCT, I would like to highlight the importance of the pre-operative ASOCT to allow the diagnosis, the surgical techniques of we are going to do. As it identifies the exact location of the corneal pathology and specify the integrity of Descemet's membrane. As you see here, this patient with the corneal opacity, he was proposed for a PKP, and after doing an ASOCT, the endothelium was healthy, so we decided to do a DALC for this patient. Postoperative ASOCT can assess many parameters, and first of all, the graft-host junction relationship. As you know, the graft-host host junction displacement is very common after PKP or DALC, and the anterior graft-host junction is generally smooth, but the posterior one can be well apposed or poorly apposed, and this is called malapposition, like we see here in this photo. So here we can see the classification of different graft-host junction. We have 4 kinds. It can be well apposed, gap, step, or protrusion. And there is these malappositions are related to the size of the graft, the type of sutures, and essentially preoperative pathologies like keratoconus and bullous keratopathy, and they induce or lead complication like higher postoperative astigmatism and poor final vision, formation of retrocorneal membrane, and early graft reject. Here, a patient who underwent PKP for corneal perforation, and on the first postoperative days, we notice a persistent graft edema with Descemet's thickening and undulation of the posterior cornea, and after surgical revision and suture repair, we note a clarification of the graft cornea, and the OCT showed a better alignment of the graft-host junction and a reduction degrees of the corneal thickness and the undulation. OCT can allow central corneal thickness. It's a quantitative method for evaluating corneal graft edema after PKP or DALC, and especially when it is associated with the posterior corneal undulation, it testifies at an acute graft rejection. So on anterior segment OCT can allow rapid diagnosis and then therefore early treatment. Peripheral anterior synechia cannot be detected with slit lamp biomicroscopy, so ASOCT can visualize this PAS because it is important to know this, that PAS can lead to secondary angle closure glaucoma and then graft failure. As you see here with this patient, he has a peripheral anterior synechia, and after peripheral iridotomy, we notice partial reopening of the iridocorneal angle. Here the cornea, the angle is open, but here peripheral anterior synechia persists. Like for DALK, we can see increased IOP due to iridocorneal angle closure. And here, after PI, we notice with the ASOCT a total reopening of the angle and normalization of the IOP. Descemet's membrane detachment is common after a DALK, as you know, and we can do the diagnosis with a slit lamp biomacroscopy, as it shows double anterior chamber. But ASOCT can better show the exact position of the Descemet's membrane, and also can show the reapplication of this Descemet's membrane after intracameral air injection. More rarely, we can see this after PKP, as you see here, this patient with corneal graft edema and Descemet's membrane detachment, and after intracameral air injection, we see a resolution of the corneal graft and reapplication of the Descemet's membrane. And this situation appear after 28 years after penetrating keratoplasty for keratoconus. Keratites and corneal ulceration can be followed and evaluated with the ASOCT, and the important thing that ASOCT can evaluate the thickness of the corneal graft near of the ulceration, so it can anticipate the risk of perforation, like this patient who had ulceration, and we see on the OCT that the corneal graft is very thin, so we decide to do a second PKP before corneal perforation. And finally, ASOCT can detect a rarer case of keratoconus progression, as we see here, a thickness of a thinning of the cornea and protrusion. So, and finally, we can say that anterior segment OCT is a useful imaging technique to assess and monitor corneal transplant surgery. It enables safer follow-up and contributes both to early identification of postoperative complications and therefore a rapid management. Thank you for your attention. Here is my great team, and this is our hospital. Do you have questions for me?
Yes.
First, I have a question for you. Do you do systematically ASOCT after penetrating or DALK? Penetrating keratoplasty or DALK? Yes.
Anterior segment OCT, and the things which you have showed actually they were very practical, and they are commonly especially the peripheral synecdoche, they are normally seen after doing the penetrating keratoplasties, and that is very beautifully elaborated in your talk.
Yes.
Very nice talk.
Thank you.
And I think for the audience about OCT, it's now very important, and it's allow us to do all pathology of cornea and surgery and the follow of surgery. in graft, in all surgery of the cornea and pathology of cornea. It's very important to have it to take care of pathology of cornea in
Yes.
generally.
Yes, of
Yes.
course. Even for trabeculectomy too. I do this for
Yes.
trabeculectomy after cross-linking to see the line. Mm.
Yes, yes, yes.
Right.
Thank you.
Good morning, everyone. I'll be talking about tectonic penetrating grafts today. As you all know, the word tectonic is Latin for tectum, and that generally means a roof. And this is the kind of graft we use to cover a small defect and actually restore the structure and the integrity, the structural integrity of the cornea. The various types of tectonic grafts can be temporary. These are basically those grafts which are used for the restoration of the structure, and later on they can be replaced by good optical quality penetrating keratoplasty. And then you can have permanent tectonic grafts in which the graft quality is such that the optical quality is also restored at the same time. Here in our part of the world, particularly where I'm working, we get a lot of agricultural trauma and a lot of infections and ulcers, and unfortunately, quite a lot of our patients are ending up with this picture. And as you can see, the whole cornea is involved and is one big abscess and has started to melt. And in fact, there is no chance of actually restoring any kind of structure for this particular cornea. So in these kind of cases, what we try to do is that first we try with the amniotic membrane because that has a good quality of anti-inflammatory, anti-infective properties, and we use fresh amniotic membranes for that purpose. And if that doesn't serve the purpose, then we go for conjunctival grafts. And if, as luck would have it, we have a corneal graft in hand, we use that also. So depending upon what kind of graft is available, we actually try to restore the structural normality of this patient. The sterile defects are smaller and probably easier to manage because then you can make do with smaller pieces. We are doing a lot of penetrating keratoplasties in our center, so we do have leftover graft pieces and corneal scleral buttons that can be used for smaller defects, and they can be used to cover these kind of smaller defects in these cases. It is a good thing if we can use general anesthesia, but if the patients are old, as it happens in most of the cases, and they are immunosuppressed, then general anesthesia may not be possible. And you can use a mannitol infusion if the cardiovascular status allows it to reduce the intraocular pressure and to prevent the vitreous from pushing the old material out as soon as you open the eye and remove the necrotic tissue. Viscoelastic material should be injected to hold the structural, the rest of the structure of the eye in place. Trephination should be done very carefully, and then effort should be made to remove all the necrotic tissues. And then a healthy donor button is then, like sutured with the normal 10-0 nylon sutures, as in other cases. As I've already mentioned, the various materials that are in use are the cornea, the sclera, amniotic membranes, tissue adhesive material, and even Gore-Tex can be used. So that is a very useful material in case you don't have anything in hand that can always be used. This is a typical corneal tectonic graft or a small perforation, and this we use from a leftover button of the corneal sclera that we had from a patient. Because of a lot of research going on in that, cryophrasing of the corneal scleral buttons as soon as you have used the donor cornea and cryophrasing it in the Optisol GS in which you get it immediately makes it possible to use that cornea later on, and small pieces of that leftover cornea can be used for sealing these small perforations. So all of you who are doing penetrating keratoplasty, please do utilize those leftover corneal buttons and freeze them immediately. Because of the acellularity, because of course the cellular component is lost, the risk for rejection is reduced quite a lot in these patients. And in fact, it's a very helpful material to use. So the leftover corneal scleral buttons from the donor tissue that come from penetrating keratoplasties can be used for these small perforations. Here we use the whole cornea, and the patient, as you see, had a necrotic area. We had a few patients in which there was a the limbal area was quite necrotic. And in those patients, we kept the central cornea and we used the corneal scleral button that we had left behind from another penetrating keratoplasty case, and we sutured that into place. So that's another good option that should be kept in mind and can be utilized for these patients. And this is the first slide that I showed you, and quite a good result. We were very happy with this particular patient. Unfortunately, we could not give her general anesthesia, and we used the local. So you must be able to, you must be seeing these hemorrhage from the local anesthesia that's quite visible, because an inflamed eye having local anesthesia injectable can result quite a hemorrhage. Another good case, the entire central cornea melted away, and we treated that with one of our again, I cannot stress the importance of maintaining and preserving the corneal tissue that you remove from the patient's eye. This particular cornea was that from a keratoconus patient, and we utilized his cornea for giving some kind of tectonic stability to this patient of ours. And I think it worked pretty well. And is it going back or forward? Okay, yeah. So I was just telling you that this entire central cornea is melted away, and this tissue was that from a patient of keratoconus. In our part of where we work here in Pakistan in particular, donation of corneas is an issue. People don't donate their corneas. So we are dependent upon the rest of the world, particularly in America. We are getting a lot of corneas from America. We are very thankful to them, to the Association of Pakistani Doc Physicians in North America, who keep on sending us these corneas free of cost, I must say, because they pay that, and these corneas are received as a part of our donation system. And we are benefiting a lot of patients in our area because of the high ratio of corneal ulcers and patients left with adherent leukemias and dense corneal opacities. These corneas really come in handy in those patients. And then we have patients who have keratoconus, and the leftover corneas, as I said, can immediately be they can be preserved in the Optisol GS material, which you are getting the actual corneas in, and they become acellular, but again, the optical quality is not bad, and the inflammatory reaction is quite less. Here again, we have used a small button of the cornea, and as you can see, this was a very small perforation, and the leftover corneal button provided quite a good coverage. Here we used, this was a resistant case. I brought this case up specifically to mention here that there are some cases in which no matter how many grafts you do, they keep on, there's a graft failure and graft rejections and recurrence of infections. So we were left with nothing but to put a sclera. This is sclera actually. So, like a very unsightly condition. But it was essential to maintain the structural integrity of the eye, such so that we could provide him with a cornea graft at a later date. The patient, of course, wasn't very happy, but he was happy with the fact that his eye was no more purulent and the infection was controlled. But again, the optical quality and the look of the graft was very unsightly. This is basically a amniotic membrane. We're doing quite a lot of those. Actually, we are using fresh amniotic membranes because I find that their anti-inflammatory and anti-infective quality of the fresh amniotic membranes are much better than those which are preserved ones. And as a regime of a post-operative, of course, you can use steroids, but again, you can't use it very liberally because of the reason that most of these patients are infective, and if there is an active infection, steroids have to be kept at bay. And again, with immunosuppressants or cyclosporines, that's the same problem. Especially in old age patients, tolerance is again an issue. But cycloplegics, monitoring of the intraocular pressure is, I think, mandatory and is probably done in almost all the cases, and all of us are doing that. And then again, the routine, once we have done the graft, the removal of the sutures after 3 months when the integrity, as you see whether it is, and then you can remove the whole sutures. And hopefully at the end of the day, you'll be the patient who is happy with his structural integrity, which you are happy with his structural integrity, and he is happy with the optical quality of the graft. Thank you so much.
Thanks very much. We're taking questions here.
Yes, sir. Yes. Yes. The Optisol GS, in which it has come in the Optisol GS solution, sir.
That is only for 15 days.
Yes, but if you get, you can still use it if you keep it in the Optisol GS that you get. So
If
it
you
gives you a margin of 15 days. Yes, agreed.
After 15 days.
You have to just discard it. There is no option in that.
And one more, you mentioned to freeze it.
Yes, it should be frozen in deep freezer. It
All
should be
right.
frozen. Otherwise, that Optisol GS would be useless. Yes, sir. You are absolutely right. Yes. Also, we keep it in a deep freezer. And as I said, at the end of the day, beggars can't be choosers, and we are unfortunately on the other side of the world. Anyone else?
Yes.
Thank you. Yes, please. Yes.
Sophia, the case where which you use scleral grafts.
Sorry?
Scleral graft.
Yeah.
It's allograft or it's allograft?
No, it's not allograft. We used it from the corneal color buttons I've just mentioned. It's not an allograft. We didn't use an allograft in this particular patient.
Okay.
The case that I showed.
Yeah. Okay.
Yes, please. Frankly speaking, Dr. Saab, I don't use systemic steroids in infective keratitis patients because that actually augments and increases the rate of infection. Well, that's a different case altogether. Then that depends upon how much of the infection is left. And even then, if you can do with the minimum if required. Minimum if required, yes. Thank you very much.
The next speaker would be Lukman Bahu. Yeah. Lukman Bahu, the toxic endothelial syndrome.
Bismillahirrahmanirrahim. I am Muhammad Lukman, working as a professor and head at Symp, Bahawalpur. Today talk I dedicate to the institutes where I got trained and to my mentors and my supervisors. This is a case, second post-operative day. The patient presented with this picture. Are there residents here? Any resident? No. Okay. So in post-operative second day, I noticed there was slight striate in uncomplicated cataract surgery. And when I stained that patient, there was this type of staining. And after 1 week, the picture was like this. And on staining, the patient was having this picture. So what comes in your mind? Top of the list. Anybody?
Punctured erosion?
At the end of the talk, we should be knowing what is toxic endothelial syndrome, a toxic anterior segment syndrome, and we should be differentiating it from endothelitis. That was the picture on 1 week post-operatively. You can notice a very specific pattern in this patient. From 12 o'clock to 6 o'clock, from 3 to 9. And when endothelial cell count was done, this was the picture of the right and this was of the left. And retroillumination, you can see what's going on in the stroma. And later on, 2 weeks, the picture was like this. I did a B scan just to see or differentiate from the endophthalmitis that can be viral. So we should be knowing what happened to that patient. And that was actually the causes we should be having in our mind, that there is decreased nutrition from the aqueous, which can cause endothelial cell damage, or there is subclinical inflammation, decreased innervation, or exposure to vitreous. But in any routine cataract surgery, which thing can cause this endothelium toxicity? Anything which you are using that can cause endothelial toxicity, right from your ringer solution, your gels, your intracameral drugs, anything. So that was diagnosed on the day 2 when it came, and we just manage it. And you notice there is this sort of discharge on almost 4 weeks post-operatively, because I gave him periocular steroid, because steroid is the mainstay of treatment in case of anterior segment syndrome. And you can notice the pupil, and there is anterior chamber reaction, of course, which can differentiate you from this. And one thing I would like to highlight, this type of discharge that happened because of the depomedrol, that is methyl prednisolone acetate, that was used. And the culture was sent for this culture sensitivity. This was a typical presentation of that patient, that he actually had 1 year ago a pterygium surgery. He was having this sort of stigmatism. After surgery, the stigmatism and autoref, see the readings. Unfortunately, the patient get better, but he encountered, as Professor Sophia was mentioning, that there are a lot of traumas or fungal infections going on in our area, Bahawalpur. So he went somewhere, and he had this picture, and he developed the fungal keratitis. With the trauma, he went to some namaz-e-janaza at that day, what I encountered, and that was get better by the treatment later on. What we can do at our levels. The take-home message for the talk is to diagnose as soon as possible. And one thing important is your corneal staining. When you're thinking at a periphery that it might be whether an endothelial problem or endophthalmitis, so just stain that. It can give you many clues regarding endothelium. And the second thing, you have to treat aggressively such patients. So thank you. Anything to discuss? Any questions?
There is any questions in the room?
Thank you.
The next presenter would be Madam Mariam, and she's going to talk about how to make my keratonic patients happy with EvoVision ICL phakic implants.
I will speak about how to make my keratoconic patients happy with EvoVision ICL. We know they have a huge irregularity in the cornea in keratoconus, and why we can add some visual acuity for the patient. You know that keratoconus is a progressive corneal ectasia characterized by stromal thinning and protrusion resulting in myopic shift and irregular astigmatism. So the phakic implant in keratoconics which it's placed in an intraocular, so behind of the cornea, which is irregular. So the implant will correct refractive error, myopia, and astigmatism, but it doesn't correct irregular astigmatism, and it doesn't reduce high-order aberration. So what are the indications making happy patients? First, the implant will be placed in first intention on stable keratoconus in the first stage. So if we have contraindication to a LASIK for thin cornea or flat cornea, if we have contraindication to LASIK because the cornea is damped, and we can use implant ICL when the keratoconus is advanced, but we have a best correct visual acuity, it's plus than 510. This is example. We have an early stage of keratoconus. We have few or no high order aberration. The irregularity is not so big. The pachymetry is 495, and the patient is not happy. He have intolerance of soft contact lenses. So this person is not happy. Like in this case, we can place intraocular lenses, phakic ICL. It will be the best solution to make this keratoconic patient happy. This case, it's severe keratoconus. The Kmax, it's more than 64. We have the best correct visual acuity is insufficient at 310. We have high sphere and cylinder, and we have important high order aberration with coma. So to have efficiency of the implant ICL, we must first begin by regularize the cornea by corneal surgery, by PRK, topoguided or aberroguided, and with intracorneal rings. So the intracorneal rings who correct the irregular astigmatism and high order aberration. And after, the second surgery will be the ICLs. So secondarily, beyond 3 months post PRK or intracorneal rings, the implant phakic surgery will be correct myopia and the residual regular astigmatism. So the patient will be happy by the 2 surgeries. Which phakic implant in keratoconus we can use? With choice, it must be have effectiveness, predictability, stability of results, and security. This it's Evovisant ICL, foldable phakic implants for posterior chamber that meet these specifications. More than 20 years, 25 years of experience, and more than 1 million procedures. So its optical zone project to the corneal plane is amplified by factor of 1.25 times. So no induced astigmatism with this implant, no added aberrations like halos, indicates even in large scotopic pupils, the columnar lens comes closer to the nodal point in the ocular refractive system, so we have a good image on the retina. I show you my experience for 28 eyes minimum follow of 2 years, and the indications is the 2/3 for contradiction for LASIK, and we have for beginner keratoconus, for advanced keratoconus after intracorneal rings, or to correct myopia and astigmatism after keratoplasty for keratoconus. Now we have the AS OCT CASIA 2, who is help us to have safety and effectiveness of the keratoconus, the ICL in the keratoconus. So we have anatomical security because they give us the crystalline lens rise. It's if under 600 micrometer we are safe. They give us the anterior chamber depth, and it will be more than 2.8, so it's good. And we have the sizing of the ICL with the Nakamura formula, with what is the diameter of the lens, and what is the expected vaulting of the lens in postoperatively. The ACT or CT CASIA 2, the AS CASIA 2 is we allows us to expand the indication of ACL in keratoconus. Why? Because by the analysis, this example, we have the axis of the astigmatism, the flat axis, it's 130. With this axis, the visual acuity is 310. It's 410, the best correct visual acuity. But when we analyze the Fourier analysis by the anterior OCT, it sends the astigmatism by the regular astigmatism, and we have the asymmetric astigmatism on the axial map, and the axis of this asymmetry, it's the same axis of the coma. So when we take the axis by the asymmetry on the Fourier analysis in the ASOCT, the best visual acuity rises to 810. So it's the same, but this axis is not good, but this axis is good, and we have a good visual acuity. So with this analysis of this axis asymmetry in the anterior axial topography, we have a good indication for toric ACL in this patient, intolerance to contact lenses, and the uncorrected visual acuity post-EVO ACL for this patient, it's 910. This is the OCT also. No, we have to enhance the results of the surgery. Now we use before. When we can play the video, please. This video. You can play the both videos. The two videos you can. So before you can accelerate, you can do. So this is the alignment of the axis of the toric ICL in perioperatively. Before we used just manual alignment. You can advance here, please. So we do that manually. We do the Mendes, and now yes, with Mendes we do the alignment of the axis of the toric ICL. And now you can advance this surgery, please. You can go for the right. So here we have with the Callisto, we can adjust very, very closely at the axis of the astigmatism. The example, it's a clinical case. We have a young man who has interrupted the two contact lenses, and his refraction is there. Is this? The top is he's not happy. This is his topography. I have a huge irregular astigmatism. So the first surgery we received the two cornea rings to regularize the cornea first. So in 2021, he has the glasses, and he's happy by glasses, but he wants to not to have glasses now. So this is the topography after corneal rings. The astigmatism was 10, now it's like 5. This is a refraction after rings, -6 and -5 at 150. This is OCT, and we see here the rings. So we can implant the phakic IOL Visent ICL. The Visent ICL is -2 +5, and here is the slit lamp photo with the rings and the implant. And this it's the slide of OCT. We have the rings and we have the implant ICL. And the uncorrected visual acuity is 1010 with intercorneal rings and EVO. He is very happy. So the conclusion is historic ICL implants a refractive correction for shoulder for myopia and regular astigmatism in keratoconus, efficiency, predictability, result stability, safety, low complication with reversibility, and good indication in datus cornea and subclinical keratoconus. Its large optical zone, its strong refractive power, sphere and ceiling make it the indication of surgical keratoconus. Thank you for attention.
Okay, we have now the next speaker because we have to hurry up
Thank you.
as we are running short of time and we have to finish this session by 12:30 and we have still speakers left. So I'll be inviting Saad Wahab if he's here. Saad Wahab. Yes. Saad Wahab is going to present the Gemini secondary IOL tips and tricks.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Thank you very much for the kind invitation. This is my first time in beautiful country of Pakistan. I'm really enjoying it. It's been beautiful so far. I feel slightly worried because I'm a retina surgeon in a cornea room. So please bear with me and
Same
do-
here. Same here. I'm sharing the same thing.
You're a retina. Okay, so at least I have somebody with me. Okay, so without further ado, I'll take you through some of our experience with the Yamani technique. Now, before I do that, I want to just introduce the concept of the fact that there are other options. So please remember this. If you're considering a secondary IOL for a patient, then remember there are other options. And to my experience, ACIOL has been great. I have followed patients for more than 20 years with great corneas and a 20/20 vision. But what we're talking today about is the scleral fixation and the sutureless one. Now, Yamani introduced this technique in 2014, and from that time, there's been a lot of modification, but the basic principles stay the same. The idea is to try to fix a three-piece IOL through the sclera without suture. So this is a no suture, no glue, quick and not as invasive as other procedure. It does require a learning curve, but once you master it, it becomes a very quick and nice procedure. Now, to my experience, I think there are few critical steps. The main ones I would think of are the needle entry, the engagement of the haptic, and finally the centration. And remember, it's a cascade of events, just like doing phaco, I guess, for an anterior segmental cornea surgeon. If one step does not do well, then the other step will make you pay. So let's start with the needle entry. The proposed needle is the 30 gauge TSK needle. Now, why is it proposed? Because it has a big lumen. I personally do not have it. I don't think it's available in all places. So what I usually use is a regular 27 or 25 gauge needle. Bend it 8 or 6 millimeter. It will make your entry easier, and try to make a tunnel. That is very important. If you don't do a good tunnel, at least a 2 millimeter tunnel, your lens will tilt and you will not have good results, and you run the risk of dislocation a couple of months down the road. Now, let me just share with you a couple of videos. This is inferior is a dislocated one-piece IOL that we're going to remove. I just want to show you the importance of marking. Very important to make sure you're marking 100 symmetrical, 180 degrees from each side, and watch how you go through the tunnel. You try your best to cover the tip of the needle through the sclera before you change your direction and go inside the eye. The second important critical step is engaging the haptic. And for those of you who have done the procedure before, they know very well it is not the leading haptic, it is that trailing haptic that will give you trouble. So there are a lot of people who do the leading haptic very easily. Actually, some people have advocated engaging the haptic as you squeeze the lens through the injector. You can do that, but you require a second assistant. I would prefer that you will dislocate present the lens into the anterior chamber, use a 25 or 20, even 23, 27 would be better. When you're holding the haptic, depending on the lens you're using, you have to be easy because you can easily break the haptics if you grasp the lens very aggressively. I'm going to show you this video in a patient. Again, same principle, trying to create a tunnel and then going in. And you can see the leading haptic usually is very easily introduced. And yes, try to feed more than what you think when you're feeding the haptic into the lumen of the needle, because the last thing you want to do is coming out and then finding that your haptic is not there. Multiple entries will give you more trouble. Now, one thing I want to say, because I'm talking to an anterior segment surgeons, you guys probably prefer anterior infusion. I personally don't like it. I was not trained to do that. I find pars plana infusion much easier. I have seen lately a lot of anterior segment surgeon insert a pars plana infusion. So I think if you know how to do it, there's nothing wrong with that. It gives you better stability. Now, 99% or 95% of the times, I don't even have to put it on. I just put it for security. Now, the last thing is the centration. And as I said, it's a cascade of event. So if you do the first two steps well, usually your centration will come without trouble. If you mark properly at 180 degree, if you do your scalenal tunnel in the right width, and what I usually do, I cauterize the tip. I hold it 1 millimeter, the haptic 1 millimeter from the tip, and I cauterize until my forceps. That gives me better size of the tip. You have to have the right size. If it's too big, it will bulge through the conjunctiva and the patient will complain. And if it's too small, it will go through the tunnel and then it will dislocate. I think Dor came up with this forceps that you see on the lower right side of the slides, which seems to be useful. I personally never used it. I don't have it, but I think for a beginner, that might be actually a good idea. This is a 27 gauge vitrectomy case with iridoplasty, as you can see, in a patient who's aphakic. And again, the same principle stays the same. You have to have good marking. You put your IOL in the anterior chamber. You insert your tunnel through the needle. You feed your haptic, and you, as I said, you feed a little bit more. Some people would leave the needle at this stage. I like to remove it, and then I cauterize my first haptic as I go, and then I do the second. And again, this is where you usually have an issue if you are not in the right plan. Probably also if you're not ambidextrous, you have to be trained, because using different hands and different techniques might actually give you trouble. But you can see at the end of the procedure, the pupil is round and the patient usually are very comfortable. And I can show you immediately post-op, you can hardly notice the bulbs of the haptics or the edges of the haptics. And within a few months, they just disappear. And I have to say, most of my patients do not feel them. And again, the trick is to cauterize the right size of the bulb. If you make it too big, it will irritate the patient and create some inflammation. So in summary, you'd like to use, now they advocate these lenses, the Sensar or the CT Lucia, the Zeiss lens. I have used the Alcon lenses. They're not as good, but they're also fine. I personally prefer the pars plana infusion approach, but I think it has been done with an AC maintainer. 25 gauge forceps in my hand is better, but I think 23 will do the job. And the trick is to cauterize 1 millimeter only from the edge, because if you do more, you will have a big thing that will not rest under the conjunctiva. Thank you very much.
Thank you very much. It was very Saad Wahab. We're going to take questions at the end of the session. Now we have to finish the session. Now the next speaker would be Ahmed Mohammad Usman. Yeah. Okay, and
next.
So we almost right. So I just.
It's you. Okay. So we have for Sir Ali
Yes.
to see the role of toric IOL in terms of visual impairments in cases of keratoconus.
Okay, thank you very much. I'm Dr. Lizan. I'm a professor of ophthalmology in King Edward, and I'm a chief consultant in Eyelid Retina, and I'm a vitreoretinal as well as a corneal refractive surgeon, as we have already discussed. So the next, basically, it's just a brief introduction. The first time I was implanted in 1949, toric was in 1998, and my aim is basically to give patients a happy refractive status after a high astigmatism. Now, what we get supposedly, suppose this is the patient which presented to me. Yeah, this is a patient of the refractive status. He came to me because of the central retinal vein occlusion in the left eye. His left eye was the good eye, and he was there to get it traded. And I say, okay, I mean, I cannot see anything from a right eye. It's dead for years and years. This was what his perception was, because he came for the central retinal vein occlusion, which was fine, and he was doing good with his working eye. So when I saw that this was the state of the stigmatism, although it was not high, the cornea was all fine. So instead of, I mean, we implanted and he was happy, and he was, I mean, after the toric IOL implant, the patient got full 6x6 20/20 vision from this eye, and he forgot about this eye, which was in the healing phase because of the central retinal vein occlusion that was treated after later worse. So the point was, this are the kind of the patient which we normally see in cases of, I mean, these are the patient, they are not going to, they have got mixed astigmatism, as Madam Mariam have already explained. They would not be having a good vision even with the glasses. They are not happy with the glasses. They say that we are fine without glasses and we cannot see anything, and maximum vision is 660 or counter finger without correction. So these were the patients for whom we have decided, and we have started implanting the toric IOL, and some like this, high astigmatism like -10, minus 9.75. So my basically the point is that we take the best corrected refractive status of the patient through autoref, and then we use some gadgets. We use IOL master to get the exact biometry and see how much astigmatism is there. And then if it's available commercially, we get it and we implant it. If it's not commercially available, then we customize those IOLs. So my personal experience with the toric IOL in cases of high astigmatism, the patient which were not responding to glasses, is so good that the patient can have, I mean, there is a huge improvement. Even if you go for ICL and implantable contact lenses, they have got a good improvement. But once you put in right over the, at the refractive site of this eye, if you put the intraocular lens with the toric IOL, that has got immense effectiveness in giving the excellent post-op vision. Supposedly this was, I mean, we normally use the Alcon lenses, I mean, and this is the toric IOL which we use normally to calculate the astigmatism, and then we correct such kind of astigmatism. So my basic talk was to give this inside, वीडियो लगा दीजिएगा, एक मिनट के लिए वीडियो कर दीजिएगा और patient who are having keratoconus, and if they want to get rid of glasses, that is the best way to make them glasses free. So we do the markings, and after taking good incisions, we implant the. So the basic is the pre-op workup. Exactly the we have to take out. That's it. Slides पे आ जाइए दोबारा. Slides पे. Now, this is the study which we are conducting, and we are continuously doing in inducting patients which are having keratoconus, which are say no to LASIK. Most of the patients, they are no to LASIK. We have received a lot of referrals, patients who are using -8 astigmatism, -7 astigmatism, and they want to get rid of glasses, and the underlying pathology is keratoconus, and still we are not going to help them in any way. So what we normally do is, in cases of high astigmatism, high myopia, we do argon laser barrage, a very thick argon laser barrage, and we implant the toric IOLs. The thick argon laser barrage preoperatively in high myopic astigmatic patients which having underlying pathology of keratoconus has got a very excellent result. A patient is, I mean, merely counting finger preoperatively, and we do and his refractive error is maybe minus 18, minus 19, minus 20, with minus 4 and minus 5, minus 7 astigmatism. And if we do toric IOLs, customized toric IOL, even if some residual of minus 3 or minus 2 cylinder is still left, the patient is going to have an excellent post-op vision if you are able to implant the centered IOL. The inclusion, I mean, of those patients are those which have got no corneal opacity. Advanced keratoconus having no corneal opacity, that is the patient which should be included for the study, and they are the patient who are going to give you the excellent results post-operatively in vision. Other patients who are having the opacities, they are basically, and the other thing is CXL. All those patients who are having a keratoconus have clear corneas, having a corneal thickness of like 435, 450 micrometer, and their corneal stigmatism is not progressive. Better do, if it's progressive, do CXL. Wait for 6 minutes, wait for 6 months, and do this toric IOL. If the patient is not having progressive keratoconus, then we can go even a stable category, we can go straight with the toric IOL, and the patient will have a good, excellent post-op vision and results. After doing this CXL, the chances of having the progression later on in the life would be reduced. So it's better advised if you go for CXL pre-operatively, maintain the cornea and stable the cornea, give the patient see after 3 to 6 months. Normally I do it after 3.5 to 4 months, and we make the patient totally glasses free, most of them, except the few of the patients which were mentioned by Dr. Mariam, the patient having mixed astigmatism can be combined with intacts. But even after intacts, if you do for implant, toric IOLs, my personal experience is far better with the toric IOLs to give excellent post-op vision in high myopic keratoconus patients. This is an ongoing study, and hopefully it will be published. And 26 patients who have been operated. So far, we have got a very promising results. So I personally believe that this is a very promising condition. If you have a patient who want to get rid of glasses, you should be given a chance to make him or her glasses free. The forum is open. That's it. Thank you. Any questions? Yes. Yes, so normally those patients who are very young, coming for LASIK, 20 to 25. Yes. The patients who are very early, I also give them that there's a chance. If there's just one eye involved, then straight away go for the toric IOL. Because we cannot, ICL is an option which we normally give the patient, but that has to be removed, and it's not permanent. That eventually will develop cataract and all.
But that preserves the accommodation of the patient.
This is what I'm saying now. If the patient is having one eye involved with high astigmatism and things are like that, so normally we go for categories. Other eye will compensate for the near vision. I normally don't go for the multifocals, because multifocals in keratoconus patient, they don't have got that good, and in that high myopic astigmatism. Or what do is I change the power. If I make one eye emetro, I slightly keep the other eye -2, -1.5 myopic. Normally I leave the astigmatism of -2 diopter. That actually accommodate for the near vision to an extent. And if at all a patient is wearing such a high astigmatism, and properly counsel that if you have to read at near, you have to wear some reading glasses, then normally they're happy to getting rid of high glasses.
Ali,
Yes.
you do cross-linking necessarily for before ICL surgery?
No.
No. So as in your slide, it's okay.
Not necessarily. If it's stable, if it's unstable,
If
then
it's stable,
yeah.
yes.
It's a young patient, then
exactly.
we do CXL, and then
yes, because the procedure is not
not required.
well, it's
for that.
evolutive.
Yeah.
The collis. Okay. Thank
Yeah.
you.
Thank you very much.
Yes, I would now like to invite our next speaker, Dr. Chen, for his talk on the effects of obesity and the risk of keratoconus. Dr. Chen, is he here? No. And if Dr. Chen is not here, then Dr. Liu? Dr. Liu is here. There are no other speakers? That's it? Okay.
We were hurried up. I thought there's a lot of.
So we have enough time. So we can
have it
discuss.
on
Yeah,
discussing.
wait. to one by one, if you.
Now, we discussed with the traditional cataplasty first. If any question regarding traditional cataplasty, we can discuss it step by step. We discussed the first case of traditional cataplasty where we use the cornea. Is there any other thing which you want to ask? Okay. The next was biological stimulation, a new therapeutic alternative for intraocular surface diseases, in which we use the PRP as a substitute and use all those PRP substances, the rich plasma, and formed a gel and implied over the cornea and place a contact lens over it and stimulate the natural healing process of that. Is there any question regarding that talk, please? Okay, the next was a contribution of anterior segment OCT in corneal graft. If there is any question regarding it. Right, right. Then there was a very excellent talk by Madam Sophia, tectonic pen graft. Yes. Yeah, right. Okay, all the speakers can come forward and we can have a photograph of this session, and it's about to end now in 8 minutes. Yes,
It's finished. Thank you.